Hi friends, today we will discuss ultrasound guided transgluteal sciatic nerve block. This is my introduction. There are 5 common techniques to block sciatic nerve. These include parasacral sciatic nerve block, transgluteal sciatic nerve block, gluteal crease sciatic nerve block, popliteal sciatic nerve block, and anterior sciatic nerve block. In this presentation we will discuss ultrasound guided transgluteal sciatic nerve block. The objective of this presentation are to discuss relevant anatomy of the sciatic nerve, preoperative assessment and preparations, indications and contraindication of transgluteal sciatic nerve block, complication and side effect of transgluteal sciatic nerve block, prerequisite of transgluteal sciatic nerve block, equipment and logistics required, ultrasound settings, making position for transgluteal sciatic nerve block, conduct of transgluteal sciatic nerve block, intraoperative care, postoperative care, and clinical tips. Relevant anatomy of the sciatic nerve. Sciatic nerve is the thickest nerve of the body, about 1.5 to 2 cm thick. Sciatic nerve arises from the lumbosacral plexus in the pelvis, from ventral lemmi of lumbar 4, lumbar 5, sacral 1, sacral 2, and sacral 3 nerves in front of the piriformis muscle. Sciatic nerve leaves pelvis through greater sciatic foramen. It travels down in the gluteal region between ischial tuberosity and greater trochanter. Often it is slightly closer to the ischial tuberosity under cover of gluteus maximus muscle. At lower border of piriformis muscle, it enters the posterior thigh. In its path in thigh, it is crossed over by long head of biceps femoris muscle. Main trunk of sciatic nerve consists of 2 components. Number 1, tibial component arises from the ventral division of ventral lemmi of lumbar 4, lumbar 5, sacral 1, 2, 3 nerves. The peroneal component arises from dorsal division of ventral lemmi, lumbar 4, lumbar 5, sacral 1, and sacral 2 nerves. Sciatic nerve divides in tibial nerve and common peroneal nerve at approximately 6.5 cm above the popliteal crease. There is wide variation in division of sciatic nerve, that is 5 cm to 18 cm above popliteal crease. Rarely it divides in gluteal region. This is the diagram showing the root value of the sciatic nerve and its terminal branch. In the yellow color we can see common peroneal nerve, and in the green color we can see the ventral division. It should be noted both are the division of anterior primary rami. This is the diagram showing formation of sciatic nerve in the pelvis. In the pelvis you can see lumbar 4, 5 as the arrow indicate, and sacral 1, 2, 3 making the sciatic nerve. And there is piriformis muscle in their superficial relation or posterior relation to the sciatic nerve. This is the diagram showing the sciatic nerve in the thigh. We can see clearly it runs over the 4 muscles, very clear in the picture. These are superior gemellus, obturator internus, inferior gemellus, and quadratus femoris muscle. This is a diagram showing surface anatomy of transgluteal sciatic nerve block. We can see the nerve runs in the mid of thigh from above downwards between 2 osseous landmarks, clearly palpable. Relations of the sciatic nerve. Anterior relation or deep relation of the sciatic nerve are 4 muscles in the gluteal region. In the pelvis, at its formation, the sciatic nerve is related to body of the ischium bone. In the gluteal region, sciatic nerve passes behind superior gemelli, then obturator internus muscle, and then inferior gemellus, and then quadratus femoris muscle. All 4 muscles are in a row. From there, the sciatic nerve comes in the thigh. In the full length, only 1 muscle is anterior to it, that is adductor magnus muscle. Posterior or superficial relations of the sciatic nerve are: in the pelvis, sciatic nerve is formed in front of piriformis muscle. So the piriformis is posterior to the nerve at the start of its formation. In gluteal region, sciatic nerve is covered by gluteus maximus muscle only. In the thigh, it is crossed over by the long head of biceps femoris muscle. This diagram shows the anterior or deep relation of sciatic nerve. We can see it comes in the posterior gluteal region from the lower border of piriformis and runs over the four muscles. We can see superior gemellus, obturator internus, inferior gemellus and quadratus femoris. These four muscles lie anterior to the sciatic nerve, and we can also see the long head of biceps femoris in posterior relation in this diagram. This is the diagram showing sciatic nerve in gluteal region and in thigh. It's clearly visible. The long head of biceps femoris is cut to show the full length of sciatic nerve and its division at the apex of the popliteal fossa. Branches of the sciatic nerve. Articular branches arises from gluteal region to the hip joint. Muscular branches from tibial component innervate semitendinosus muscle, semimembranosus muscle, long head of biceps femoris muscle, adductor magnus muscle. The short head of biceps femoris is supplied by the common peroneal nerve. Cutaneous branches are sciatic nerve carries cutaneous sensation from all leg and foot except areas supplied by the saphenous nerve. This is a diagram showing muscular innervation of tibial nerve and common peroneal nerve. Common peroneal nerve is depicted in green color and the tibial nerve is depicted in orange color. Sciatic nerve has no cutaneous branches for the thigh. It innervates skin in the lower limb, leg and foot through tibial and common peroneal nerve except the area of the medial border of the leg up to the big toe, which is supplied by the femoral nerve. Perioperative assessment and preparation. These preparation we do as a routine, take history, do physical general examination, we request for labs, do look for comorbids and optimize the comorbids. We take consent, confirm NPO, side marking is done in the holding area. Indications and contraindication of transgluteal sciatic nerve block. Indication of transgluteal sciatic nerve block include anesthesia and analgesia for posterior thigh, leg and foot. Above and below knee amputation can be performed in combination with femoral nerve block. Surgery on tibia and fibula, cuff and Achilles tendon repair, analgesia for cuff tourniquet. The popliteal sciatic nerve will not work for tourniquet pain. Ankle surgery with saphenous nerve block and foot surgery, vascular surgery and lower limb surgery can be performed. Most of the time we do surgery in the lower limb in combination with femoral nerve block. Contraindication of gluteal crease sciatic nerve block. Absolute contraindication are same as patient refusal, inflammation or infection or injection site, allergy to local anesthetic. Relative contraindication include patient on anticoagulant or patient with bleeding disorders. Pre-existing peripheral neuropathy where sensory block may mask compartment syndrome. Complications. Intra-arterial injection can cause hemorrhage, bruising, hematoma, and the drug is lost in the vascular compartment. If the drug is injected intravenously, it can cause local anesthetic systemic toxicity. The incidence of intraneural injection is very high, which is 16.3%. We should take care of it. There could be partial block or failed block like any other block. Introduction of infection, it needs sterile technique and taking care of this problem. Allergy to local anesthetic drugs could be a complication. Prerequisite of ultrasound guided gluteal crease sciatic nerve block. Block is executed in an area designated for regional block. All facilities of converting the patient to general anesthesia must be available. Sterile technique must be used. We need bright light source. We need 18 gauge working IV access. We need all standard monitor to be attached. All resuscitation drugs must be in hand, including lipid emulsion to manage local anesthesia systemic toxicity. We need trained assistant for ultrasound guided regional anesthesia. Equipment and logistic required. Ultrasound machine with a high frequency linear probe. We need sterile gel, sterile probe cover, and sterile gloves, sterile towel to isolate the block area and sterile cleansing solution. We need pressure measuring syringe with tubing. We need local anesthetic for puncture site analgesia Local anesthetic volume may be 15 to 20 ml for the block. A safe dose should be calculated based on weight of the patient. A 22 gauge insulated blunt bevel echogenic needle 100 to 120 mm long is required. We need sedative analgesic, midazolam, fentanyl and ketamine. Facilities to convert the patient to general anesthesia must be available. Ultrasound setting. Adjustment in gain, focus, depth, etc. are made before the execution of procedure. We put ultrasound machine on contralateral side in front of our eyes. Color Doppler can be used to avoid intravascular injection. We use in-plane technique. Out of plane may be used. A 100 to 120 mm 21 gauge or 22 gauge short bevel insulated stimulating needle is required in 70 kg person. We keep the angle of needle with probe at 180 degree. We use part to obtain the best view. See the next slide. Depth setting is 4 to 8 cm depth. This is the diagram showing part maneuver. The P denotes pressure and the A denotes alignment, up and down movement to have a best view. Then rotation, then T for tilt. Making position for transgluteal sciatic nerve block. Lateral position is usually practiced. The operator side is kept uppermost in lateral position with hip and knee flex. A pillow under the head to relax neck muscle. A curvilinear ultrasound probe is placed in a transverse orientation in the area between the greater trochanter and ischial tuberosity. Depth setting is 4 to 8 cm depth depending on the weight of the person. Elevate the bed up to avoid bending of the operator. We put ultrasound machine in front of the patient while standing in front ensures a good position for the operator to view the screen and perform the block comfortably. We can stand on the same side depending on our experience and practice. This is a diagram showing position of the transgluteal sciatic nerve block. The operator is standing in front of the patient and the ultrasound machine is on the contralateral side. This is my favorite position. Conduct of the transgluteal sciatic nerve block. Sign in and site marking is done in preoperative holding area. We make lateral position of the patient for this block. We do sonotomy before preparing and draping the block area. We use sterile preparation of the area and isolate the area with towels. We use puncture site anesthesia. We identify orientation of probe site and apply gel on the probe. We put curvilinear ultrasound probe transversely at mid-gluteal area to identify ischial tuberosity and greater trochanter of humerus. We identify gluteus maximus muscle and quadratus femoris muscle. We identify flat, thick, hyperechoic sciatic nerve and facial plane between gluteus maximus and quadratus femoris muscle. Inferior gluteal artery is a useful landmark to locate sciatic nerve on ischial tuberosity end of the sciatic nerve, means on the medial side of the nerve. We optimize the image, adjust depth, gain and frequency setting. An in-plane approach is usually used from lateral side. Out of plane may be used. Needle is inserted from lateral aspect near greater trochanter. We use hydrodissection to open interfacial plane between gluteus maximus and quadratus femoris muscle. We inject a total volume of 15 to 20 ml of local anesthetic in 5 ml aliquot. Every aliquot should be followed by aspiration to avoid intravenous injection. The spread of local anesthetic should be observed at all times. In this diagram, ultrasound probe position for transgluteal sciatic nerve block is shown. Two bony landmarks, that is greater trochanter and ischial tuberosity, are seen and the ultrasound is positioned between them to view the sciatic nerve between the quadratus femoris muscle and gluteus maximus muscle. Again, this is an anatomic view of the transgluteal sciatic nerve. In this, gluteus maximus muscle can be seen under the skin, and then hyperechoic sciatic nerve is easily visible, and we can inject in the subgluteal area in the interfacial plane between the gluteus maximus muscle and quadratus femoris muscle. Again, this is a diagram showing the phonoanatomic view of transgluteal sciatic nerve block. In this, gluteus maximus muscle and the quadratus femoris muscle are clearly visible, and even inferior gluteal artery is visible on the medial end of the view. It is near ischial tuberosity. Again, this is an anatomic view of the sciatic nerve. Two bony landmarks are easily visible: ischial tuberosity and gluteal trochanter. Sciatic nerve is depicted in yellow color. Quadratus femoris muscle and gluteus maximus muscle are visible. Operative care. We brief all details of the block to the patient before starting procedure. We apply full standard monitoring as for general anesthesia throughout the procedure. We avoid hypothermia and use full body bear hugger. We test motor and sensory block before tourniquet and incision. We isolate the limb by full screen. Pseudoanalgesia can be given, but better after confirmation of the block. Pseudoanalgesia can mask signs of local anesthetic systemic toxicity. Monitor for local anesthetic systemic toxicity, and we keep in hand lip emulsion in OR and in recovery also. Alternatively, we maintain close verbal communication with the patient for monitoring the local anesthetic systemic toxicity. In case of inadequate block, we get ready to convert the patient to general anesthesia. Post-operative care. After completing procedure, gently transfer the patient to post-anesthesia care unit. We apply all standard monitors. We monitor the patient for local anesthetic systemic toxicity. We inform patient about the approximate time of return of sensation, and we prescribe oral analgesic in advance before the block wears off. Early mobility is possible. Early resumption of food and drink is allowed. Early pain-free physiotherapy can be done. We exchange cell phone contact with the patient to assist any case of problem or queries. Required documentation are: we document the side of the leg, right or left lower limb, or we document the site of the nerve block out of 5, which nerve block we are doing. We also document the positioning of the patient. We also document in-plane or out-of-plane technique, needle size and type, local anesthetic name, volume and concentration used. We also document ease of injection, pain on injection, and negative aspiration. Clinical tips. Sonotomy is necessary before practical conduct of block to view anatomy and if there is any variation in anatomy. Operator works on the same side and ultrasound machine is kept on the opposite side. We use curvilinear probe for wider visibility to scan greater trochanter and ischial tuberosity in single scan and view in depth of 4 to 8 cm, which is difficult to view in a linear probe. In-plane technique is usually used. Out of plane may be used. Sciatic nerve is the thickest nerve of the body, and set time can take 30 to 45 minutes, and the patient may not demonstrate a profound motor block. Always give support to the probe hand and the needle hand. Advance needle only when the full needle is visible with bevel cut. We use hydrodissection to reach the facial plane to reach the sciatic nerve. We don't direct needle to the center of the sciatic nerve even in out-of-plane technique. Posterior cutaneous nerve of thigh can be blocked in the same plane. Color Doppler should be used to identify and avoid vessels. Inferior gluteal artery is a useful landmark to locate sciatic nerve. Avoid intravascular injection by aspiration each time we inject. We avoid intraneural injection by we note the pain on injection. It is the earliest sign of intraneural injection in a non-sedated patient. We never inject against high resistance more than 15 psi. Even expert can miss intraneural injection, and the incidence of intraneural injection is very high. We always note local anesthetic solution visible on injection in required area. We use nerve stimulator at 0.1 milliampere and 0.1 millisecond to exclude intraneural injection. Thank you.